HPV, which is human papillomavirus, and some of them are very dangerous and can cause serious health problems, including cancer. And those types could be HPV type 16, HPV type 18. Cervical cancer is the most common type of cancer caused by the HPV infection, and the second most common cancer amongst South African women. And if we may just recall on the first day's presentation from Dr. Jafta, we were told that when we look or zoom down to Eastern Cape, it's one of the most common cancers, because if you look at South Africa as a whole, breast cancer is the first one. So it's really an issue and a very health problem. So our problem statement was that limited understanding and awareness of HPV and its prevention contribute to suboptimal vaccine uptake and inadequate prevention strategies. Therefore, by this, the aim was to assess knowledge and awareness and attitudes towards human papillomavirus amongst AYPs in selected sub-districts. We used a cross-sectional survey which was conducted across 5 sub-districts, namely Nelson Mandela Sub-District C, Enyandeni Sub-District, Dihlabeng, Setsoto, and Fitahomo Sub-District. The sample size for this abstract was 787 adolescents and young people, and they were aged 15 years to 24 years of age. The data was collected using a Microsoft form questionnaire. If we look at the research design, it's a convenience sampling method targeting AYPs. That is, we targeted all the AYPs that are under the Global Fund-funded AYP program. So it was convenient for us as the people doing the research. Focused on demographics, HPV awareness, knowledge of transmission or prevention, and attitudes towards vaccination. The data was analyzed using descriptive statistics to summarize key responses as we used the Microsoft form as a questionnaire. So all the data that was collected, we used and analyzed it so that we are able to present the results. The time frame for this survey was February and March 2024. The following were the key findings from this. Under awareness, when you look at awareness, 55% of participants had heard of HPV, and 27% of the AYPs were aware of the HPV vaccine. And if we look at knowledge, 34% correctly identified sexual contact as the primary mode of transmission. If we look at knowledge, 34%, if we look at the other one, 22% were aware of the importance of regular screening. It moves on. Looking at the attitudes, 79% expressed interest in learning more about HPV, and 65% indicated willingness to receive the vaccine if made available to them. So with these findings, the results highlight significant gap in HPV knowledge and vaccine awareness. A strong interest in health education presents an opportunity for intervention. The main findings are that limited knowledge about HPV transmission, prevention, and vaccination amongst adolescent young people. A high willingness to learn and vaccinate if given access. So looking at the implications for public health, to develop targeted educational campaigns to address knowledge gaps and increase HPV vaccine accessibility and awareness programs in sub-districts. Now looking at the limitations, self-reported data subject to bias. We know that some adolescent young people might feel like when they are filling the survey or the questionnaire, they are supposed to answer the correct answer answers only. So this would then make it difficult to get the raw knowledge of what we are talking about. So this is what we are talking to here. And future directions: to conduct longitudinal studies to track changes in HPV knowledge and vaccination rates, and partner with schools and community organizations to disseminate information effectively. Thank you so much.
Thank you very much for your presentation. And I think your recommendations were quite clear in terms of how do we increase knowledge and uptake around HPV vaccination. Colleagues, questions, comments? We'll take hands at the same time. So I've got one there. Any other hand? No. 2. 3, okay.
Okay, thank you so much, Chair. Thank you so much for the presentation. It's so informative. But I'm having some few comments and questions because I'm very passionate about pap smear, because pap smear, that's where we diagnose these pre-cancer cells that are caused by this HPV. My first concern is looking at the age group, it's 15 to 24. And when you look at the pap smear, I will start with the pap smear first. When you look at let me start with the vaccine. The vaccine currently is given to girls 9 years and older. And now when you look at this cohort, it's 15 to 24. I'm not sure if they do have an information quite clearly. I don't know whether it was supposed to be done to those that are about to get this HPV vaccine, because in most cases, the uptake is poor. The parents think otherwise. They have no knowledge about the HPV vaccine. And the girls that are taking this vaccine are 9 years old. They are not in the cohort. Secondly, the target even for pap smear now, coming to pap smear, where you will be able to diagnose if there are pre-cancer cells caused by this HPV. And currently, I believe there's a study checking on HPV. The target even there is 30 years and older. I don't know how are we going to catch these 15 to 24.
Thank you.
Thank you. Very, very well done. For me, the age disaggregation, are you able to go back to your data so that we can be able to see, instead of grouping it into 15 to 24, can we at least have a sense of which age group, which band is giving the responses in terms of willingness to be vaccinated? Very much related to the previous comment, but again, those that missed it earlier on, if they are interested, then that's a positive in terms of knowledge. Thanks.
I should think I'm covered.
Thank you, Mamgedi. So we've got those questions to respond to.
Thank you so much. Thank you for the questions. Maybe if I may start with Doc's question and comment. We would be able to go back to the data and get that kind of data, even though we won't be able to get the data as of now. So I'd be happy to share the data with you, Doc. So to go back to the other comment or the question, I understand that the group that we have is from 15 to 24, and when we look at the HPV vaccination, as you had mentioned, it's from 9 to 15. However, there is a catch-up because some of them might have missed those vaccines, you know. So I believe that it's very important that they are well informed about this HPV, or even for future purposes in terms of prevention strategies, they'll be able how to prevent themselves from catching this infection, because we know that it's one of the most commonly sexually transmitted infection. So it's more of getting them to be more knowledgeable about the infection, so that they are able to protect themselves in future. Because we know that if we look at the statistics in terms of cancer, the prevalence is very high. So one of the problems maybe it's lack of information. So we know that when we look at HPV, it's one of the infections that cause cervical cancer. So if they are well informed about HPV, not mainly focusing on the vaccine, because we know that they might have missed the vaccine, they might have received the vaccine, so they'd be able now to protect themselves and be able to maybe not be part of the people that are infected or have cervical cancer. So that is the reason why we looked into it this way. And also the education might also even go to parents in the communities. You know, when you empower one person, they'll be able to empower their parents. Who knows? So even for the next generation, will be well informed and protected. So that is where we looked into it. Thank you.
Thank you very much. Yeah, especially the parents, they need to understand the HPV vaccination, because they continue to be a stumbling block in the uptake of the vaccine when they refuse to consent for their children. So thank you very much, Sia, for that presentation. Colleagues, let's move along. Our next presenter is Ms. Fikile Sohuma, and her presentation is the impact of patient-centered HIV services on HIV treatment and preventative practices in Gqeberha, South Africa, from March 2022 to November 2023. So Fikile, you will introduce yourself and tell us where you come from. Do we have Fikile's presentation? Sharp.
Morning, everyone. My name is Fikile Sohuma. I don't know whether I'm loud enough. Morning, everyone. My name is Fikile Sohuma. I'm working for the Department of Health. I'm also the board member of the Sustainable Innovation Foundation. The research was done by Sustainable Innovation Foundation in collaboration with the Department of Health. The topic is the impact of patient-centered HIV services on HIV treatment. Preventative practices in Gqeberha, South Africa, from March 2022 to November 2023. The research came about the fact that Nelson Mandela have got a challenge of high fatality rate, especially on HIV patients. As we all know that the department has done a lot, there are so many programs on HIV preventative strategies and also treatment. But it seems as if we are not winning. So the patient-centered care, which emphasizes tailoring healthcare services to individual needs and preferences, has shown promise in addressing these challenges. However, there is limited evidence to its effectiveness in the South African context. This study evaluates the impact of patient-centered HIV services on treatment adherence and preventative practices in Gqeberha between March 2022 and November 2023. The study aims to address this gap by assessing the impact of patient-centered HIV services on treatment adherence and preventative practices. As I've already mentioned about the aim of the study, so I think we can just pass. The research objectives were to evaluate that HIV services on treatment adherence among individuals receiving antiretroviral therapy in Gqeberha, South Africa. The second one was to examine the influence of patient-centered HIV services on the adoption of preventative practices, including pre-exposure prophylaxis, PrEP, condom use, and regular HIV testing, and also to identify the barriers and facilitators affecting the successful implementation of patient-centered HIV services in Gqeberha. Research questions were, how do patient-centered HIV services impact treatment adherence among individuals receiving antiretroviral therapy in Gqeberha, South Africa? The second one was, what is the influence of patient-centered HIV services on adoption of preventative practices such as PrEP, condom use, and routine HIV testing? And the last one was, what are the key barriers and facilitators to the successful implementation of patient-centered HIV services in Gqeberha? The hypothesis was thus, patient-centered HIV services significantly improve adherence to HIV treatment and uptake to preventative practices in Gqeberha, South Africa. The second one was the implementation of patient-centered services leads to increase in PrEP uptake and most consistent condom use among patients. Another one was patient satisfaction with HIV services is positively associated with adherence to treatment and participation in preventative practices. The last one was addressing identified barriers to patient-centered care delivery enhances overall program effectiveness. The research methodology, this was a qualitative exploratory descriptive study employed in-depth individual interviews and focus interviews, and focus group discussions. 45 individuals were interviewed, and these 45 individuals that were the 2 churches that were sampled, and 5 focus groups were conducted across 3 churches and 2 student residents. All 400 participants received HIV, self-test kits, and condoms. Those on treatment and also those tested positive were provided counseling and attached to peer educators for treatment intake. The study population was approximately 200 individuals. And based on the standard sample size, the calculation formulas for proportion sample size of 400 participants were appropriate for the study. Data collection, focus group discussion, and in-depth interviews with 155 Nelson Mandela students and 200 congregants and 45 healthcare providers in churches. What happened? Let me first talk about I'll talk about it later. The semi-structured interviews, focus group discussion, and open-ended survey questions were used. Focus group discussion were used to identify barriers to adherence, patient preferences and perceptions, quality care. Depth interviews with participants were used to explore their experiences with patient-centered HIV care. And lastly, depth interview with healthcare providers were used to discuss barriers and facilitators in delivering tailoring services. Before we go to the interventions, what happened is this: we used the method where we went to the church to get approval to conduct the study. Once the approval was granted, what we did was using the convenience setting where we will sit in front of and who would like to be part of the study was included in the study. The same method was also used even with the university student, where we'll stand outside anyone who is interested and then will be part of the study. Then after we did, thank you. After we conducted the interviews and have our recommendations, we started to do, sorry, can we go to the interventions? We started to do the interventions where after people were given the self-test kits, or even before they received the counseling, and also we ensure that we supply condoms in all the 3 churches. We're still supplying them, and also in the student residence. We also ensure that those that were started on treatment and also those that are tested positive, they were attached to the peer educators. Sustainable Innovation Foundation does have peer educators, and also Health Promotion for the Department of Health does have peer educators, so we attached them to the peer educators. So also those that were interested in taking PrEP, we also liaise with the clinics that were closer to them, so that we do a referral so that it can be easy for them to start PrEP. Okay, patient satisfaction and retention in care programs. We did the in the focus groups. We did ask the questions to check if they were happy about the program, but we'll find about it when we're talking about the results. Okay, data analysis. Data was analyzed thematically to identify key trends, barriers, and facilitators of patient-centered HIV service implementation. Perceived impact of these services on treatment adherence and preventative practices. A structure matrix was used to organize data around predetermined themes aligned with the study objectives, which were treatment adherence, preventative behaviors, also barriers to implementation. Qualitative data analysis software was used, which was in vivo, which allows for efficient coding, categorization, and theme identification was employed. On the results, the HIV treatment outcomes, that was the first one. The patient receiving patient-centered services showed a significant improvement in the treatment adherence at the rate of 85%. On preventative practices, PrEP uptake increased by 45% among participants. Condom use reported during the follow-ups to increase by 70%. 100% of participants expressed a strong preference of patient-centered HIV services. Getting services in churches, that was their preference, at homes and also in student residence. Notable 78% of participants took self-testing kits for their partners, extending preventative reach. It was so interesting, especially sorry, ma'am. Okay. Thank you. With the results, participants reported higher satisfaction with services that offered flexible hours, privacy in testing, and personalized counseling, which fostered trust and mitigated stigma. Key barriers include stigma, logistic constraint, medication burden, and negative interaction with health workers. Findings, patients emphasize the importance of flexible service hours, personalized care, and improved communication with healthcare providers. Key barriers included transport cost, stigma, and lack of community awareness about patient-centered services. Healthcare providers highlighted that patient-centered services foster trust and improve patient retention. Overall impact was patient-centered HIV services were associated with improved adherence, better clinical outcomes, and increased engagement in preventative practices. Participants reported higher satisfaction and trust in healthcare systems. Conclusion. Let us go to the last one. Inclusion of patient-centered services are a promising strategy to optimize HIV care and prevention. Scaling of these approaches while addressing barriers and limitations could significantly reduce the burden of HIV in resource-strained regions.
Thank you very much, Fikile, for the presentation. Sorry to put you under pressure. I said 7 minutes, so I'm strict on time. They are ready to chase us out because they want to do the closing session. So can I ask that we do questions at the end? Colleagues, can we note the questions for Fikile and then just take the next presentation so that we can be able to finish on time. So colleagues, our next presentation, Mr. Musanduli will be presenting to us enhancing TB screening strategies and comparative analysis in school and out of school adolescent and young people in Fetahomo sub-district in Limpopo. So Mr. Nduli, you will introduce yourself and tell us where you come from, and then you take us through your presentation in 7 minutes. When you hear my phone ringing, it's 7 minutes. Yes. And then this is how you change your slides, or you can negotiate with the DJ to change for you.
Morning, ladies and gentlemen, and non-gender conforming colleagues. My name is Musantuli from IHPS, Fitahomo. Can I have my presentation on there? Don't start the timer, Madam Chair. The topic of the abstract has already been shown, so I'll go straight to the introduction, to the background. So the background is TB is a thorny, persistent problem across the globe, including South Africa, and this necessitates finding innovative strategies to find the missing cases of TB. Most importantly, you must take note that we are implementing the Global Fund program funded by Beyond Zero, focusing on adolescent and young people between the ages of 10 to 24. So the research hypothesis is there is no difference in TB positivity between in-school AYP and those that are out of school. So we have got beneficiaries that are in school and those that are out of school. So this is a comparative analysis between the two groups. And the aim of the study is to explore differences in TB positivity rates between the two groups. This is a quantitative study, and the research design is cross-sectional, it's a comparative cross-sectional study, and we are focusing on adolescent and young people between the ages of 15 to 24. looking into the period, data that we collected was from April 2022 to September 2023. And we are comparing the TB screening, those that were having presumptive TB, and those who were having confirmed TB, those who were initiated on TB, and we also look, shortly on HIV. And the data that we're using come from KIVEP. This is a routine data that was generated from KIVEP, and we have used the chi-square to do the data analysis. Can we move to the next slide? So the result are as follows. For TB screening, the large number of people that were screened for TB at over 33,000 were in school. Around 31,000 were out of school. The presumptive TB found to be so high on the in school with blue at 88 compared to 45 at out of school. However, this is mind-boggling because when we come to the confirmed TB, only 6 cases of the in-school confirmed TB compared to 15 out of 45 out of school were having confirmed TB, and all of them were put on treatments, meaning that we had 33.33% of those that were out of school who happened to have confirmed TB compared to 6.82% of those that were in school. When we conducted the what we call the chi-square, the p-value was less than 0.001, which is less than 0.05 threshold, meaning now the statistic was significant, and there's a significant difference between the two groups. And as such, the null hypothesis is rejected in favor of the alternative hypothesis that indicates there is a difference between the two groups, and all were HIV negative. Go to the conclusion. So the findings have demonstrated the significant difference of TB positivity rates between the in-school and the out-of-school groups. This disparity in TB positivity between in-school and out-of-school implies a plausible protective effect of attending school, which is mind-boggling. And we don't know the reason why they're out of school, because initially we thought maybe because schools are congested, maybe they're infecting each other. However, the picture was contrary. Continuous research remains very critical to fully understand the factors giving rise to the TB positivity rate among in school. And also looking into the zero TB HIV positivity rate among those who were screened. Furthermore, targeted, tailored, effective, and contextually appropriate TB prevention strategies are essential to ensure to address the high TB positivity rate among the out-of-school kids, and we don't know the reason why. So that's why there's a need to do further research and to also delve deeper into qualitative studies, as a follow-up study after this one. Ladies and gentlemen, thank you. I think I've given you bonus of my time.
You saved me 2 minutes. Thank you very much. So colleagues, we will note questions from Musa. We'll take questions at the end. Our next presentation is the presentation that is online. Will be presented by Rosie Mkabisa, looking at trends in drug-resistant TB transmission, a high prevalence of primary infections. Is Rosie online?
Yes, I can hear you. Okay. Can you see it?
All right, so we'll start. Rosie, you've got 7 minutes for your presentation. Thank you. Over to you.
Thank you so much. Thank you for inviting us to present this work. I am presenting on behalf of Dr. Emily Street, who couldn't make it last minute. So forgive my, if you see me doubt or stuttering a little bit. I'm still trying to familiarize myself with the presentation, but I'll give it my best. So the title of presentation is Trends in Drug-Resistant TB Transmission. High prevalence of primary infections. Am I audible? Can you hear me well? Okay. So as we might all know, in 2022, tuberculosis was the second highest infectious disease killer globally. And this is despite effective treatment that's been available and that cures patients when they started on treatment timely. There was a report by WHO in mid-October or towards the end of October that actually shows that TB has reclaimed the spot of being the top highest killer, infectious disease killer globally, having overtaken COVID in 2023. And what's worrisome is the increasing frequency of drug-resistant TB, quite frequently in most settings. Currently, with the drug-resistant TB, it accounts for about a third of all antimicrobial resistant deaths, which is a worrisome figure. And what's been said is that only 2 out of 5 patients with drug-resistant TB actually seek treatment according to the recommendations by WHO. So 60% of DR TB cases remain untreated, which increases the risk of community transmission. The drug-resistant TB, it emerges by acquired resistance due to selection pressure from inadequate treatment or incompletion of a treatment. For patients that are diagnosed with treatment, they either don't complete treatment or somehow they don't take the correct dose for their body weight. But we're noting that primary drug-resistant TB infections via community transmissions are now the common route of transmission. So we wanted to understand from the cohort of patients we see, it's not really a large number, but from the small cohort we see what our patients are presenting with. Are we seeing more TB acquisition from community transmission, or is it acquired resistant? So we wanted to better understand the main route of transmission of drug-resistant TB patients that we see and describe the length of symptoms the patients have prior to diagnosis of their drug-resistant TB. So we are the Enhancing Care Foundation, which is a research organization located in Devon. We conduct most of our trials in Wentworth, and most of the TB trials we conduct are drug-sensitive TB. But as we do cultures, we note that some of the results will come back with showing a drug resistance. So we reviewed participants that had diagnosed drug-resistant TB, and we use summary statistics to describe the data. So in total, we reviewed 31 charts, and the median age of the patients that we reviewed was 30, and most of them were male at 68%, and 55% of them were living with HIV. 87% of the patients were symptomatic prior to diagnosis. Even when we saw them, the symptom duration varied from 2 weeks to about 6 months prior to diagnosis and prior to them being started on treatment. Most patients had never been tested or treated, had never been treated for TB prior to these episodes, and only 5 reported a history of a previous TB. 4 of the 5 were people living with HIV. Of the 5 that reported a previous history of treatment, only 1 had completed their treatment. So as you can see, 61% of them had MDR, and there was a few that had rifampicin-resistant TB. We also saw some XDR and pre-XDR. As mentioned already, there was 55% of the patients who had HIV. So Majority had never been treated for TB, 84% had primary drug-resistant TB, and very few had TB treated previously. So most of the participants in this cohort that we reviewed had primary drug-resistant TB, and which confirms that community transmission is becoming the primary route of transmission for drug-resistant TB. The prolonged symptom duration is concerning. As I mentioned, that is up to 6 months prior to them diagnosed and started on treatment. That alone increases the risk of community transmission. This highlights the importance and need for intensified prevention and screening efforts to improve early diagnosis and treatment of those with DRTB. Our implications without prevention is key. Timely screening and treatment of close contacts with patients diagnosed with drug-resistant TB needs to be a priority. Community-led efforts such as screening by community-based healthcare workers or with collaborations through NGOs or faith-based organizations that are located in communities are critical in fighting and eliminating the scourge of DRTB. We do note that because the cohort that we analyzed was small, it thus limits generalizability of our study results, but it does point on what worrisome trends are there in our communities. So thank you so much. These are the references that were used, and that is, I hope I was managed to finish on time. Thank you for listening.
Thank you very much, colleagues. We've got a few minutes for questions. So if there's a burning question for the three presenters that have just presented, we'll take the questions. And any questions for Rosie, you'll have to come and stand here on the laptop so that she can hear the question as she's online. Questions, comment, going once? Going twice? We've got a hand. Going thrice? Gone. Dr. Kaga, uyakuthanda uvukelwa. Uyathanda uba last minute. Is your hand up, ma'am? Is your hand up? It's not. Okay, so it's Dr. Kaga and our gentleman. Please introduce yourself and ask your question.
Good morning to all right. Good morning, everyone. I am Kobani. I'm from Umtata in an organization, Isikula Sonke, a board member of the organization. I have a question for Ms. Figile. I'm not sure. I thought she'll be there so that we can go back to the slide. I think I missed her. I'm not sure she was even fast, but I think I missed her numbering in terms of, she says there were 45 people and also continued to say 400 participants were given medication and PrEP, what, but I think for clarity, she needs to clarify that. Also, let me leave some questions. Also, she says there were key trends that they identified towards the last slide, but I don't think she did mention what are the key trends that they identified. Mr. Is fine.
You can also continue the conversation during lunch, ne? Dr. Gaga, Dr. Mzi, you forfeited your spot.
Thank you, madam. It's for Fikile. Fikile, thank you very much for your abstract. But I was just curious, Fikile, how did you select the churches and the universities? Maybe even if you don't answer now, maybe we can have one-on-one. Remember in Gqeberha you have many churches. So how was it a purposeful selection? Same with the universities. Thanks.
Fikile, you can respond.
Thank you for the question. Let me start with your question, Doc. Yes, indeed, it was a purposeful selection with the university and also the churches. We've got more than 100 churches in Gqeberha. With you, sorry, your name? Xolani, I was saying the population was 4,000 and the sample size was 200. In that 200, we have 45 healthcare providers. And then we have 155 Nelson Mandela University students. And then we have 200 congregants. By the congregants, I mean everyone who participated from those three churches. We had 5 focus groups. Focus groups were for the congregants and And the in-depth interviews were for the healthcare workers. Yeah, for the healthcare workers, it was about the barriers. That's what was the most, questions. Come again? In the study, ne? Was it not in the?
Yeah, I think you can engage later. I think Mina, my comment on Fikile's presentation, it felt like a PhD study. You had 3 methodologies and you had 3 objectives. So probably you have to separate them and make each objective a different study so that you can focus to say on this study, this is the methodology and this is your population and this is your result. Because we've got different results for different groups and different methods. So don't clump them in one abstract. It's 3 abstracts actually that you have. So yeah. Colleagues, thank you very much for being a wonderful audience. So we already have people walking in so that we can continue with the next session, which will be the closing session for the conference. Thank you very much. Fikile, can you please come? We just need a picture with the presenters.